Thank you very much. It's a pleasure and a privilege to be here this morning and present data describing inhibition of PD-L1 by the monoclonal antibody PD-L3280A, leading to clinical activity in patients with metastatic triple-negative breast cancer. And I'm pleased to do this on behalf of my co-authors. These are my disclosures for your review. Now, triple-negative breast cancer typically has a worse prognosis than other breast cancer subtypes. In addition, there are no approved targeted treatments available for patients with triple-negative breast cancer in the United States. So we are left with the use only of chemotherapy for patients with this disease. Outside of the US, bevacizumab can be used for triple-negative breast cancer. Triple-negative breast cancer is a particularly interesting target for cancer immunotherapy, particularly PD-L1 targeted therapies, for a variety of reasons. First, triple-negative breast cancer tends to have a higher mutation rate than other breast cancer subtypes. This lends to its ability to produce neoantigens that can be recognized as foreign by the immune system and can be more effective targets for the immune response than other antigens, which tend to be recognized as self. Secondly, there's an increased number of tumor-infiltrating lymphocytes in triple-negative breast cancers relative to the other breast cancer subtypes. And these are cells of the immune system that can facilitate an immune response leading to tumor rejection. Typically, patients with triple-negative breast cancer who have high levels of tumor-infiltrating lymphocytes associated with their tumors have improved clinical outcomes. And then finally, triple-negative breast cancers typically have higher PD-L1 expression levels within their tumors. PD-L1 expression can inhibit T-cell anti-tumor responses, and this is more likely to occur with triple-negative breast cancer than with either HER2-positive or ER-positive breast cancer subtypes. PD-L3280A is a monoclonal antibody that has been engineered. It's specific for PD-L1 and inhibits the binding of PD-L1 to its receptors PD-1 and B7.1. Inhibiting these interactions between PD-L1 and its receptors can enhance T-cell priming and restore anti-tumor T-cell activity. In addition, PD-L3280A leaves the PD-L2-PD-1 interaction intact, thereby potentially maintaining more effectively immune homeostasis and potentially preventing some of the autoimmunity that can be associated with targeting this particular pathway. This is a schema of the phase 1A trial that's enrolled triple-negative breast cancer patients. This is a trial that was initially started as a 3+3 dose escalation in a variety of different tumor types. After a safety profile and an effective dose had been characterized, there were a number of expansion cohorts that were undertaken in the disease types that you see here. The focus of the presentation today is on triple-negative breast cancer. The objectives for patients with metastatic triple-negative breast cancer were to explore the safety, efficacy, and potential biomarkers of PD-L3280A activity in patients with metastatic disease in this particular clinical trial. The cohort of patients with metastatic triple-negative breast cancer originally enrolled patients that were selected for higher levels of PD-L1 expression and then was opened to patients regardless of their level of PD-L1 expression. PD-L1 expression was centrally evaluated using a proprietary assay using the SP142 antibody, and it was evaluated specifically on tumor-infiltrating immune cells within the tumors of these patients. The drug was given every 3 weeks at either 15 or 20 mg per kg or a flat dose of 1,200 milligrams. In addition to measurable metastatic triple-negative breast cancer, patients typically had an ECOG performance status of 0 or 1 and no significant history of autoimmune disease. Tumor responses were measured using RECIST version 1.1, and the clinical data cutoff for this study was December 2nd, 2014. This is a slide that summarizes both the safety and the efficacy data that were observed in this triple-negative breast cancer cohort. There were 54 patients that were evaluable for safety. These patients had any level of PD-L1 expression within their tumors. In general, in these patients, the drug was safe and well tolerated, with the most common treatment-related adverse events consisting of fatigue, nausea, fever, decreased appetite, and asthenia. There were 11% of patients who experienced grade 3 treatment-related adverse events. These included a low potassium level within the blood, a low white blood cell count, a skin rash called lichen planus, dyspnea, and adrenal insufficiency. In addition, there was one event of grade 4 pneumonitis, and then finally 2 deaths, which are currently assessed as related by the investigator, but are currently under further investigation by the sponsor. There were 21 patients who were evaluable for clinical activity or efficacy, and in contrast to the safety evaluable patient population, these are patients who expressed higher levels of PD-L1 within their tumors at levels on immune cells of 5% or greater. In these efficacy evaluable patients with metastatic triple-negative breast cancer, the overall response rate was 19%, with a confidence interval between 5 to 42, and the 24-week progression-free survival rate was 27%, with a confidence interval of 7 to 47. Importantly, these responses included 2 complete responses and 2 partial responses. And also, importantly, 3 of the 4 responses were ongoing at the time of data cutoff. Moreover, there were 3 patients who were recorded as progressive disease who appeared to experience a phenomenon known as pseudoprogression, which is an atypical response pattern seen in some patients treated with this class of agents. These are patients that exhibited durable shrinkage of their target lesions while at the same time developing new lesions at other sites. They remained clinically well with this pattern of response. This is a spider plot, which is very informative for this class of agents and illustrates the tumor burden over time. And again, this is for those 21 patients with tumors that expressed fairly high levels of PD-L1. It demonstrates the durability of the responses in those patients that did respond in this early data cut. And importantly, the median duration of response has not yet been reached. The range is between 18 to 56 or more weeks. And the median duration of survival follow-up is approximately 40 weeks with a range between 2 and 85. This is a slide that just illustrates a pattern consistent with pseudoprogression, or these atypical response patterns that you can see with this class of agents. And you can see here a patient with metastatic triple-negative disease who had 3 target lesions identified at the outset. Scans were obtained at baseline and then at 9 months follow-up and 20 months follow-up that are shown here at least. You can see that the first target at baseline is illustrated as a mediastinal mass. At 9 months follow-up, this target has decreased in size, and at 20 months follow-up, it's decreased even further. The same is true of the second target, as you can see across horizontally the CT scan cuts. And in the cuts that show target number 3, you can see target 3 decreasing in size at 9 months, but at the same time, this patient developed newly enlarging left axillary nodes that actually look inflammatory or necrotic. The patient was clinically doing quite well at this point, so she remained on therapy, and by 20 months of follow-up, the third target lesion has decreased further, and these newly enlarged axillary lymph nodes have also regressed. So this patient remains on treatment and is doing well today. So in conclusion, the data from this early study show that MPDL3280A is generally safe and well tolerated in patients with metastatic triple-negative breast cancer. MPDL3280A monotherapy demonstrates promising clinical activity in PD-L1 selected patients with triple-negative breast cancer, with 4 of 21 PD-L1 selected patients responding, including 2 patients with complete responses. Additionally, 3 of 21 patients experienced pseudoprogression and therefore derived some clinical benefit from treatment with the agent. Further evaluation with MPDL3280A is ongoing in this study in both PD-L1 expressing as well as PD-L1 non-expressing patients with triple-negative breast cancer. In addition, we're preparing to launch a phase 3 global randomized trial testing MPDL32A in combination with Abraxane as first-line therapy for patients with metastatic triple-negative breast cancer. So I'd really like to thank the patients and their families for their commitment to participating in clinical research and in helping us develop new therapies for patients who really desperately need them. The co-investigators and participating centers that participated in the study, as well as our colleagues at Genentech and Roche.
Thank you very much. So I guess we can add another disease to the list. Here's back not very long ago, people who did phase 1 clinical trials were pleased if they saw even a hint of activity that would justify moving forward into phase 2 with, suspiciously prolonged stable disease, maybe an occasional response, and that would be enough to trigger further evaluation of drugs. This is the kind of thing we're seeing with these checkpoint inhibitors, where the activity signals are unequivocal, and where I think the implications for the future treatment of people with triple-negative breast cancer are really very, very exciting. So, Dr. Emens, do you think that this is the first targeted therapy for triple-negative? Is this going to be the important target here?
And I think it very well could be the first targeted therapy that bears out in a larger trial. Of course, these data are still early, and we need to enroll and treat a lot more patients with this agent, but I think it has great promise for this particular breast cancer subtype. It's critically important for patients with this disease because, as you say, it really represents an unmet need, as it's quite an aggressive subtype of breast cancer for which the only option currently in the U.S. is chemotherapy.
Okay, we'll open up the floor to questions. If you just wait for a microphone, hold on.
Hi.
Right here.
Hi, Elaine Shatner. I'm a contributor to Forbes. Thank you. This is a really cool new drug. My concern is that for women with triple-negative breast cancer, their months are numbered, and this is essentially. And I've read about the global trial that's planned. So there are other experimental drugs that these women might choose with their doctors to try for triple-negative disease with perhaps a clearer response. The pseudo responses are interesting, but they may in fact cloud and require more time on observation. So how can you justify women with triple-negative breast cancer choosing this experimental drug over another? Essentially, it's an opportunity cost for the women.
Well, I think that this is a really interesting option for patients with triple-negative breast cancer. The phenomenon of pseudoprogression is something that's new for many physicians to manage. Typically, you have to take the entire clinical picture into account, which we frequently do in the clinic. So it's not just one thing that you look at. And an important component of the phenomenon of pseudoprogression is that if you see evidence of new lesions on a scan and the patient's doing clinically well, you continue to treat and then reevaluate subsequent to that. If there's progression at that point, then potentially you consider changing the therapy or just following the patient more closely. Another potential option to help sort through that is to try to obtain tissue from one of those lesions to get some idea of what's happening with these new lesions, if it's a phenomenon of the inflammatory response or a response to the therapy, so an infiltration of immune cells at that site, or if it's a new area of tumor. So that would be another way to help sort through it. But I think there's ways of managing that in the clinic, and it's going to be incumbent upon us who've developed these agents to educate both physicians and patients about these unusual patterns of response and how to be comfortable with it.
Okay, next question right here. If you please identify yourself and your outlet, please. Thanks.
Alice Goodman with the ASCO Post. I was going to ask you about the pseudoprogression too, because I hadn't heard that before. And does this occur with other agents that attack the immune system, or is it just with this agent? And could you just tell us a little bit more about that?
So there is a phenomenon of pseudoprogression with this class of agents in general. Those of us who've been doing this type of research for a while have realized this. Most of the trials use standard RECIST criteria to evaluate complete and partial responses. There's an alternative criteria called immune-related RECIST that allows for this phenomenon of pseudoprogression, and you can apply those as well. So that's another challenge for the field, I think, since we know that this is a phenomenon that can be associated with this class of agents where you're actually treating the immune system and not the cancer itself, where the response patterns are a little bit different. So we also need to work not only with community physicians and the patients to understand this, but also with the regulators in order to develop a consensus for really the best way to evaluate the clinical activity of these agents moving forward.
So it only occurs with the anti-PD-L1 agent?
It occurs with ipilimumab too. So I think it's a phenomenon with these highly effective immune-based agents. Yeah.
Okay, next question. Charlie?
Charles Bankhead, MedPage Today. Have pembrolizumab and nivolumab been evaluated in triple-negative breast cancer? And if so, what kind of data are available on those?
So pembrolizumab has been reported in triple-negative breast cancer in a group of about 39 patients, I think. And the safety profile is fairly similar, as are the response rates so far. For both agents, the patient numbers remain very small. But both agents are under accelerated clinical development for this particular indication.
Next question.
Thank you. Thank you, Marcia Taylor, medicalresearch.com. Are you looking at any biomarkers that you've identified to indicate potentially which patients with triple negative are going to be responsive? And are you requiring positivity and PD-L1 in their tumor cells, which in the phase 3, which you did not in phase 1 and 2?
So the biomarker assay that was utilized in this study is the proprietary assay that's been developed with Ventana and Genentech in collaboration. And that assay is the predictive biomarker that's currently used for this agent. Anything that is a level of expression of PD-L1 on tumor-infiltrating immune cells of 5% or more is considered PD-L1 positive for purposes of this particular report. Anything less than 5% is considered PD-L1 negative, even though there may be some low levels of PD-L1 expression there. So those are the parameters for the assay. For the phase 3 clinical trial, that will not require PD-L1 expression for enrollment, because it's important to validate that biomarker now in large numbers of patients. And the most effective way to do that is to conduct a very large trial in a large number of patients globally, and then retrospectively take a look at that particular assay and validate it within that set.
Next question.
Lynn Peterson with Trends in Medicine. So we've been seeing a lot of data on pembrolizumab, nivolumab, NPDL3280A, and I would ask the panel, do you really see differences in these drugs? I mean, do you?
So, yeah.
I'm asking the panel, though.
In my opinion, the drugs seem to be fairly similar overall. There are people that think that there are some differences between the drugs, and I think there could turn out to be some subtle differences between the drugs. But at this point, the drugs seem fairly similar in terms of the side effect profile and such. So, I think if there's any differences among different tumor types or across the different agents, that will remain to emerge with further evaluation.
So it's very hard to make head-to-head comparisons, and I think I look at it as we should be celebrating this field where we have companies, investigators who are investing so much into multiple agents to look at multiple different indications for all cancers. And the bottom line is that there's activity.
Hey, Dr. Hody, press your button so that everybody can hear you.
I'm sorry.
I'm
trying here. So I think we should celebrate the activity across all of these cancers, where the excitement is that we have multiple agents that companies and investigators are working on to develop across all cancers, and that we're seeing activity across all cancers. We're seeing durable activity in cancers. We're seeing durable activity in cancers that we had no prior real effective therapies for. And so we should be celebrating this and pushing and encouraging more to be done in more sets of patients and in different indications, and now combinations of the future. So I think this is just the beginning. You haven't, we're in chapter 1 of hopefully a very robust and big novel here.
Remember, where this started was in melanoma, and historically that's been considered a more immunogenic tumor, but historically has also had few treatment options until this revolution has occurred. In contrast, non-small cell lung cancer, in which these drugs have activity, as well as triple-negative breast cancer, has historically been considered a non-immunogenic tumor. So I think it's really interesting that actually targeting the immune system can make these tumors that have been considered non-immunogenic responsive to an attack by the immune system. So I think it really is quite revolutionary, I think.
Yeah, and the revolution here is about the therapeutic philosophy and the targets. It's that we're learning that the targets matter, and that by accessing those targets with drugs, we can change the course of diseases and save lives. There will be lots of work to do to figure out which drug or drugs or drug combinations are most effective for very particular indications, and we'll get there. And we'll get there because the activity signals are so strong. There will be an interest in the pharma industry in figuring out how to make that happen, and certainly physicians are going to be anxious, as you might imagine, to offer these exciting new treatments and treatment options to their patients. So I think that the critical take-home point from these two abstracts is that the targets matter. They really matter, and that the immune system can be mobilized to make powerful anti-cancer responses a reality for many patients. Okay, thank you.
Thank you very much, Dr. Emens.